My name is Paul Spiegel. I'm a professor at Johns Hopkins Bloomberg School of Public Health, and I direct a center here called the Center for Humanitarian Health. And we are thrilled to be able to present today on a project that we have been working on for a couple of years now. With me is Kelsey Vaughn, who's a health economist, and she will be, I'll be starting with the first six slides, and then Kelsey will be continuing on. So we're thrilled to have you. Some basic housekeeping, as you see, is that we're going to please use the chat feature for any of your questions. We will be following them throughout, and then closer to the end at 9:30 Eastern Standard Time, we're going to then take all of your questions. So, what is humanitarian list, and why did we decide that this was an important project? What we found in the past, and I think many of you on the webinar and who will be listening to this later, what we found is that in humanitarian assistance, we have a hard time prioritizing life-saving interventions. There's often not enough data to be able to do so, and also everyone is busy, and we wanted to develop a tool that people could use to prioritize their maternal and child responses at the beginning of an emergency and all the way through. So what we have done is we have used List tool, the LifeSave tool, and we have modified that for a humanitarian setting. So our aims of this project are to save the most amount of maternal and child lives in humanitarian settings. And it's important that we emphasize maternal and child. And how we do this is we have evidence-based interventions from the LifeSave tool, and which we'll talk about shortly. And what we look at is those evidence-based interventions, and we look at the coverages in your various settings, and we look at what your coverages are of these certain interventions and where you would like them to go, what is feasible, and then the tool will calculate how many lives, maternal and child lives, can be saved. And this is done in a proportional manner. So this was a project that was developed by the Center for Humanitarian Health and Johns Hopkins Bloomberg School of Public Health in conjunction with the LifeSave tool, which is a long-standing tool that is used by many ministries of health, as well as UNICEF, and they add an equity component to the LifeSave tool. This project is supported by the Bill and Melinda Gates Foundation. And so what is the methodology for identifying the various activities? We have here on the bottom a graphic that shows beginning. We identify those life-saving interventions, and we look at the current coverage of those interventions in your setting. And this can be done in any humanitarian setting: camp, non-camp, urban, rural, low income, middle income. We then work, or really more you, work with your partners, your health, nutrition, your WASH partners, and you brainstorm about which activities you would like to increase and what is it going to take to increase the activities to go from a certain coverage. And we're going to show you that we have certain levels of coverage. What would it take for you to move from a basic coverage that you're at now to a coverage of where you would like to go? And then what happens is, after you've looked at that, you then work with your program officers and yourselves to say, well, actually, how much would that cost incrementally, meaning additionally? And then finally, you also, not just the cost, but you also then finally look at the feasibility of doing these interventions. Some interventions you may be able to do, some may be beyond your control. And so you reprioritize the intervention, giving the costs, and then the feasibility. So what are these interventions? In fact, there are over 60 evidence-based, and that's also very important to emphasize. These are evidence-based interventions. And so that means over the years, this LifeSave tool that's been used for a long, long period of time, as I mentioned, by many ministries of health, over those years, they have accumulated evidence. And actually, if you go onto the LifeSave tool online, and we have a link for that, you can go into more detail about what these interventions are and what is the evidence behind them. But for our purposes, and because it's a humanitarian setting, we have divided these into 5 categories. So we have pregnancy, delivery, and periconceptual. And you can see underneath these antenatal pregnancy, we've put them by time. Then we have EPI, or Expanded Program for Immunization, and we have the various vaccines. We have the OPD and community outreach, which is looking at many, many different areas, a lot on children, both communicable disease prevention as well as treatment. Then we have nutrition, infant young child feeding, as well as treatment for acute malnutrition. And then finally, some of the key WASH interventions, the water, sanitation, and hygiene. Now, a lot of people ask, well, what specifically are these interventions? And so we have a slide that we don't expect you to go over in detail now, but this is on the website, of which we'll be sharing with you. So don't be too overwhelmed, but we're going to show you now all of these interventions, because I think it really allows you to really understand what we're talking about. So for example, under antenatal pregnancy, one of the interventions is, the first one is calcium supplementation. The last one in that chart here is tetanus toxoid vaccination. For labor and childbirth, the first one we talk about here is anticortical steroids for preterm labor. And all of these, what you do is you move into these areas of, let's say, pregnancy, child, and periconceptual. You look at what data you actually have that is available for your programs, and we certainly do not expect you to have data for all of these 60 interventions. It's just that these are the key interventions of which there is data. So those that you do have, you'll put them together and then look at the coverage that you are now, where you would like to go, and we have bands that will be able to show you this. And then finally, you work through, and Kelsey's going to be talking to you very shortly about how we move forward on this. So just a couple more examples. In immediate post-labor, for example, the first two are case management of premature babies and clean cord care. Under EPI, you can imagine you've got your DPT vaccinations, your Hep B, measles, etc. You've got your infant young child feeding, as I mentioned, under nutrition, but you've also got treatment of MAM, moderate acute malnutrition, and SAM. OPD, community outreach, we've got some prevention activities such as insecticide-treated bed nets, and then we've got many communicable disease treatments such as ATCs for treatment of malaria, antibiotics for treatment of dysentery, etc. And then finally we have our WASH, and some of these interventions are hand washing with soap, hygienic disposal of children's stools, improved water source, etc. So I'm going to now hand over to Kelsey, who's going to go into more details in all of these steps. But I hope you understand that, I hope I've been able to explain to you what this tool, the objectives are, is to look at lives saved, maternal and child lives saved, to be able to look at what data you have for specific interventions that are evidence-based, the coverage of your current program, and then where you would like that current coverage to go, looking at the costs and the feasibility, and then the tool will then run, and it will show you the key interventions and the list them according to the largest percentage of lives saved. So thank you for your attention, and now over to Kelsey.
All right, wonderful. So before we launch into the 7 steps of the H-list approach, we wanted to just again reiterate for what purposes you can use the H-list approach and for what purposes it might be inappropriate. This is really, really important because the approach was designed for a very specific purpose. We want to make sure that it's not misused. So let's start with what the H-list approach is. And Paul has touched on a lot of these issues, but like I said, it's important, so I'm just going to do it one more time. So H-list approach can help you to prioritize maternal, newborn, child health, nutrition, and WASH interventions. And we do that by showing you which interventions can save the most maternal and child lives compared to other MNCH nutrition and WASH interventions. We include in our methodology steps to help you identify specific activities to increase coverage of your priority interventions. We have a methodology to help you identify which additional resources you need to implement those activities. And this process can really be used in any humanitarian affected setting. So that's what it is. What it is not is, number one, a tool to allocate funding between MNCH, nutrition, WASH, and other health or non-health areas. So if you're looking for some help in deciding, do I spend money on mental health or maternal health, this is not your resource. If you're looking to make a case for spending in health versus spending in education, for example, this is also not your tool. We are also not providing any sort of justification to stop the provision of certain services. So all interventions that are being delivered in humanitarian settings are important, including the ones in the Lives Saved tool, the 60 plus interventions Paul mentioned, and interventions that are done in humanitarian settings but are not included in the Lives Saved tool. So we're not trying to tell you that the interventions that either don't make the priority list or are not included in list are not important, because they are. We're also not giving you a fully costed service package. So if you're thinking, I'm going to be able to use this H-list approach to prepare a full budget for a donor for a proposal I'm working on, sorry to disappoint. This is also not a tool that's going to tell you the exact number of lives that you can save in your humanitarian setting. As Paul said, we present the most life-saving interventions in terms of a proportional ranking of those interventions in terms of the lives saved. So we'll tell you which interventions save the most lives compared to other interventions, but you will not get a single number of lives that you can save. This tool is focused on lives saved. I keep saying that because it's important. So we're not focused on morbidity or quality of life. There's lots of interventions done in humanitarian settings that have a really important impact on morbidity and quality of life. We're not saying that those aren't important, but this tool is only focused on lives saved. Finally, this tool is not to be used in high income settings. So as Paul said, low and middle income settings only. In terms of the potential users for the H-list approach, as Paul mentioned, really any organization working in humanitarian settings can use the H-list approach. So you can use it for planning, for advocacy. Donors might be interested in the H-list approach if they're trying to put together guidance for their humanitarian partners. And as Paul mentioned, humanitarian settings include camps, settlements, out-of-camp settings such as urban areas, whether you're working with refugees, IDPs, etc. This approach is for you. So without further ado, let's just get right into it. I'm going to give you an overview of the 7 steps of the H-list approach, and then we'll go into each one in a bit more detail. So as Paul mentioned, the first step is really to figure out where you are in terms of coverage, and then you identify what we're calling prioritization scale-up scenarios. Step 2, you then examine the prioritized interventions for your setting, and this is where we access the Lives Saved tool. Step 3, you identify the incremental activities that you want to implement to scale up coverage. What do I mean by incremental? It's just a fancy word for additional. Step 4, you then estimate the incremental or additional cost of those activities. Step 5, you then do a feasibility assessment of your activities, including their cost. Step 6, you make a final decision about which interventions and activities you want to focus on. And then finally, step 7, you monitor coverage levels and adjust activities as necessary. So let's talk a bit more about the first step. As Paul mentioned, we've organized the 60 plus interventions into 5 intervention areas: pregnancy, delivery, and periconceptual, EPI, nutrition, outpatient and community outreach, and WASH. For each intervention area, you choose a coverage scale-up scenario. So you're going to choose the coverage scale-up scenario that best represents your current coverage for the majority of interventions that are included in that area. So for example, if you're thinking about the pregnancy, delivery, and periconceptual intervention area, you would look at the coverage of the interventions included in that area. And you would see, are the majority closer to 40%, 60%, 80%, or 90% currently? And based on which of those 4 coverage levels you choose, we've then defined a coverage scale-up scenario for you. So for example, if you say, my starting coverage is 40%, then you fall in the 40 to 60% coverage scale-up scenario. That means you're going to try to scale up all of your interventions from currently around 40% to a target of 60%. As you can see from the table, you can choose a different coverage scale-up scenario for each of the intervention areas. So maybe pregnancy, delivery, and periconceptual, you choose the 40 to 60% scenario, but for EPI, for immunization, you choose the 90 to 95% scenario, and so on. You can also choose different scenarios per camp or settlement or urban area. So if you're working in multiple settings, maybe with the same partners, you could run the results for each setting by choosing a different coverage scale-up scenario for each setting. How do you choose these coverage scale-up scenarios? We recommend using HIS data or similar program data. And as you can see from this slide, we did this in Uganda last year for 3 camps or settlements. And the data that you see is for the pregnancy, delivery, and periconceptual area. And we've just plotted the data per month for a period of 6 months, and then put in average lines. So those dotted lines, the dashed lines, are the average over the 6-month period, whereas the solid lines are the month-to-month data. And based on this plotting, we then decided which coverage scale-up scenario would be most appropriate for each of these camps or settlements. So in fact, all 3 camps or settlements, the majority of the 5 indicators that you can see on this slide, and the names of the indicators are seen in the upper right-hand corner there, the majority of the indicators really fell around 90%. So for each one of these camps, we chose the 90 to 95% coverage scale-up scenario. So what do you do with this data once you've identified your coverage scale-up scenario? We move to step 2, and this is where we access a modified version of the LiveSave tool. So some of you may have used the LiveSave tool list. We have adapted it to be used in humanitarian settings, because of course in humanitarian settings there are some things that are unique. We've also tried to simplify, let's say, the front end for people like me and you to be able to use it more easily than you might find the full list is able to be used. So we've given you only a limited number of data inputs. And that is, of course, your coverage, which we've just talked about in step 1. You also need to pick your country. And based on your choice of country, some country-specific or possibly region-specific estimates will be pulled from list. So things like HIV and malaria prevalence, total fertility rate, all of this data is preloaded. You have the option, but it is entirely optional, to also input 3 pieces of information. One is you can modify the existing demographic profile. So LIST automatically uses the country's demographic profile in terms of the percentage of the population that falls into male, female, and different age groups. If you know for your camp or settlement or urban area that you have a lot of under 5s, or maybe a lot of women of childbearing age, you can choose to modify that demographic profile. You can also choose to input some nutritional status information to further customize your model. So we have both stunting indicators and wasting indicators that you can enter. So without further ado, we would like to demo this. I'm going to ask Paul to go to our website, humanitarianlist.org. I would like to just note that the website is currently locked because we're in the webinar, so please don't try this at home yet, but you'll have the option to explore the website on your own time after the webinar. So you can access the menu, Paul, in the upper left-hand corner, and we're going to choose step 2 because that's the step we're on. Of course, if you're doing this in real life, you can start at step 1. And here you see the same screen that we just looked at on the slides. So first, we're going to choose our coverage scale-up scenarios. And here you do it again by intervention area. So let's choose, Paul, in the pregnancy, delivery, and periconceptual intervention area, 40 to 60%. And then we need to also tick on the left-hand side to include that intervention area. And let's also run the nutrition intervention area. And let's say for nutrition, we're going to run the 60 to 80% coverage scale-up scenario. We're not going to modify our demographic profile, but we do have some data on stunting and wasting. So let's put in that our stunting is serious and our wasting is also serious. Once you've made these selections, again, they're entirely optional. So if you don't have the data or you don't want to customize the model further, just proceed as you without entering this data. You're going to click on View Results. I forgot, of course, to select a country. So Paul is going to select the country of his choice. Perfect. And we're going to View Results. So this takes a quick second, maybe less time for Paul since he's in Baltimore, but it dials Baltimore. And you should see in a few seconds a pop-up window with the results. Just going to give this a second to open. If you want to go back to the slides, Paul, we have an example of what the results look like. It will open a pop-up window like this, and you'll be able to toggle in the upper left-hand corner to see the default option is you see both maternal and child lives saved, but you can also toggle to just show the maternal lives or just show the child lives. And the interventions are in order of lives saved. So the top intervention with the rank of 1 is the most life-saving intervention in your setting according to the information you entered. And the table also tells you what percentage of the total lives saved for your setting from these 60 plus interventions are attributable to this single intervention. It also shows, of course, the intervention area, the summary intervention group, we call it, and the coverage scale-up scenario that you chose for that intervention area, since you can choose different coverage scale-up scenarios for different intervention areas. So in this test example, our number 1 life-saving intervention is the Hib vaccine, and so on and so forth. You can also choose from our website to download these results to Excel. All right, moving on to steps 3 and 4. So once you have this list of priority interventions, then you can move forward with identifying the incremental activities to improve coverage and the incremental cost of those activities. So, for example, the first table shows dummy results. Our number 1 life-saving intervention is treatment for moderate acute malnutrition, or MAM. So we would brainstorm, and ideally you do this with all implementing partners who are working on nutrition issues. What are the activities that we want to implement that can help us increase coverage of treatment for MAM? So you might brainstorm, let's do increased community sensitization, or perhaps increase the provision of ready-to-use supplemental food. Then for each of these activities that you identify, we're going to walk through this incremental costing. Again, incremental just meaning additional. So we have a nice Excel template that already does the calculations for you. So for each activity, you would identify the inputs that you need. Is it fuel that you need for your vehicles to do the community sensitization? Is it maybe extra incentives for your community health workers, or maybe additional community health workers, refreshments for your community sensitization? Whatever it is, identify the inputs, and then the unit cost, the cost per item, how many items you need, and then you calculate your total cost. Then we move to steps 5, 6, and 7. This is where we do our feasibility assessment, make a final plan, and monitor progress. So feasibility assessment, in steps 3 and 4, we think big. We think, if I could do anything, which activities would I use? And how much would they cost? What are the additional resources that I need? But step 5 is where you really do that reality check. Do I have the resources available? Are these interventions likely to succeed, or are there factors beyond my control that are going to prevent me from having success with these activities? So for example, if you've tried to get people to use bed nets time and time again, and they're still being used for fishing and not for sleeping under, and everything you've tried has failed, you don't have any new ideas, it might be time in this feasibility assessment to say, we're not going to try that again. There might be stock out issues that are beyond your control, or other issues that are preventing you from that will prevent you from achieving the coverage scale up that you desire. So at this point, you would then remove those from the list and instead choose to focus on interventions and activities where you think you can actually achieve the coverage levels. You then add those activities and the incremental cost to your planning. So if you're making an annual plan or a proposal for a donor, you would add these activities and costs into that plan. And then, of course, we want you to monitor progress and see how it goes. Please don't wait a year to do this. Do it early and do it often, because the sooner you can identify if your activities are working or not working, the sooner you can either change the activity, or if you've had success, you can then move on and focus on a different activity or intervention. So in a nutshell, those are the 7 steps of the approach. I'm sure there are some questions. As a reminder, we're using the chat feature, which should be showing on the right-hand side of your screen, perhaps the bottom of your screen. So you can enter any questions you have there. And for now, I'm going to thank you very much and turn back over to Paul.
Great, thank you. Thank you very much, Kelsey. Beside me is Chiara Altare, who's an assistant scientist here at Hopkins, and she's going to be working and trying to collate the various questions, as well as ask some questions herself, some of them from our frequently asked questions that we have on that is currently online. So maybe, Chiara, over to you and to any questions either from the group or that you may have.
Yes, thank you very much, Paul. Good morning, good afternoon, everybody. I see that questions are coming, but let's start with one that we received a lot in the past and that could be useful to rediscuss today. So why does H-List only include maternal, child, and neonatal nutrition and wash interventions?
Sure, maybe I'll start on that, and then Kelsey, whatever I get wrong, you'll correct me. List was developed over the last decade, also through Gates Foundation, the Bill and Melinda Gates Foundation funding, and it was solely for maternal, child, and health. And so what happened is, over that time, we were able to eventually piggyback on what they have done. And over that time, what they did is they looked at all of the evidence that exists for life-saving interventions. And again, underscoring that it's life-saving. And it took a long time with a lot of work and a lot of brain power to develop a tool that will allow for putting in all the various interventions and then looking at the increase in coverage, looking at the interaction of these various interventions, and coming up with life saved. Currently, for broader issues such as male adults with non-communicable diseases, the tool it was not made for that, and so therefore it doesn't exist. Maybe someone in the future will be able to do this. I think we could all benefit from that, but currently that's not the case. I am aware that the LifeSave tool team are also working now on, in the future, and I don't know when this will be available, looking at the data and evidence behind LifeSave for adolescents as well. Kelsey, I don't know if you had anything to add on that?
Yeah, maybe just to add where the effectiveness comes from. So as Paul mentioned, all of these life-saving interventions have been collated by the LIST team at Hopkins from high-quality published evidence, and that's mostly randomized controlled trials or other experimental design studies which have proven the effectiveness of interventions, specific interventions. So we're limited to the interventions for which there is, of course, this evidence. And as Paul said, that may expand in the future. Maybe one thing to note, for the humanitarian list or H list, we have assumed the same effectiveness of interventions as is currently in list. Probably in real life, the effectiveness of some interventions implemented in humanitarian settings may differ from what has been proven in RCTs and through the evidence, but for sort of an oversimplification of reality, and because that's the data that we have available, we are assuming the same effectiveness as is currently in list.
Great, thank you. That's helpful.
Thank you. Yeah, and I think you actually addressed one of the questions that we received about effectiveness, and I take the opportunity to thank Angela, who is part of the list and who shared a link in the chat to the background papers, which is behind the list approach, and you can see all the reference to the effectiveness that is used and integrated in the list tool. But we can move to another question, which asks what is specific to the humanitarian context? So how have you adapted the list tool to the humanitarian context, and what were the challenges or the specificity of this context?
Sure. Kelsey, do you want to take this and then I'll add on?
Sure. So I think two things that make H-list specific and different from regular list, let's call it. So regular list is far more complex, let's say, than humanitarian list. It has far more options that users can enter and modify. It requires a bit more training. We really tried to simplify list and to create an interface where humanitarian actors can benefit from all the evidence that's available in list and the power of list to identify those life-saving interventions without having to enter loads and loads and loads of data. So for example, in regular list, you would need to enter the exact current coverage and target coverage for all 60 interventions. In H list, you just enter by intervention area and you choose one of our coverage scale-up scenarios. So that's the first thing. I think the second thing that really distinguishes H-list from regular list, H-list is an approach. It includes 7 steps, and accessing the LiveSave tool results is just one of those steps. So we really walk you through the whole process of, identifying the life-saving interventions for your setting, but then figuring out, what am I going to do with these results? How do I operationalize this by identifying the specific activities that can help me increase coverage, identifying what additional resources I might need, doing a reality check, is this actually feasible in my setting? And then taking it to the next step. Do I put it in my annual plan? How do I monitor coverage? All of these things really, it makes it a real approach and not just results from a model.
Yeah, thank you. I'll maybe just add and emphasize that latter approach. As I'm sure you all know, when you have an idea and then you try to make it reality, Kelsey and I hit a lot of obstacles, but also a lot of really interesting, unexpected areas to move forward. And one of them was exactly that, is that we in Uganda and then Kenya, we were able to get the health, nutrition, and water sanitation hygiene folks together in one room, and so looking at these different sectors and seeing the integration and getting all the people in the room to see how they actually work together and affect one another, and then allowing it for planning. Often the planning is done in silos, as we know, and so getting them together and think it through, and then think through the actual ways that they want to increase their coverage and what is feasible was maybe just as important as what comes out of this in terms of the prioritization, because it really allowed people to think in a different way. I think we all know that we're all so busy, so in the field sometimes people just look at last year's plan and then they look at maybe what budget they may have and then tinker accordingly. This is really a way to think through in a much more nuanced and specific way together with at least these three sectors.
Thank you. We have another question about the coverage. So how can you link how can you link the HList tool to other existing tools that can provide input? For example, the question relates to MAM and SAM coverage, and there is a method which is called SQUIC, which gives a quantitative and qualitative coverage improvement. Coverage of the nutrition programs. So to what extent is HList linked to other tools, and how could this be done? And related to this, a question about the target of the coverages. Who sets the targets?
Yeah. Okay, maybe I'll start and then we'll move it around, Kelsey, and then please add on. So this is the first iteration, I would say, of HList, and we don't currently have linkages to, for example, SQUIC and other areas. But what we want to do and what we're hoping to do, and we, as Kelsey had mentioned, we've piloted this in some countries, and we're hoping now to pilot this in many more countries, working with people such as yourselves, hopefully. And so what we're hoping is to learn and how to improve the tool, but also potentially to link, if we can, to see what may be feasible and what may not be. There are lots of different, this is like any tool and like any article that one publishes, there are a lot of limitations, there are biases as well. So just to add in terms of the GAM and the SAM issues, is that what we had to do at times to make it, the humanitarian world either measures things differently and or they have different age ranges. So what we had to do was to follow list and then make alterations accordingly. So in list, if you go into the details for the nutrition component, you'll see they have slightly different age ranges for the MAM and the SAM, and the stunting, of which we didn't have, and the humanitarian world really doesn't do it in the same way. So that's why we worked at these areas of looking at different levels of both coverage, but also in MAM and SAM, saying, well, it can be mild, let's say mild, moderate, or severe. Another modification that we did is because it got very, very complicated to be able to look at over 60 indicators, some of which you have, some of which may not exist in the field in your situation. And then number two is, how do we put them, you're going to see it sometimes in your antenatal care component, for example, or that antenatal periconceptual. You may have some that are at different levels, and you're going to be forced to choose where they most fit in and where you want to go. So we chose the 40 to 60 and not have it 40 to 60 in these bands, and not have it as an individual inputting, because it was complicated. And on top of that, list was developed for more low and middle income countries that are stable. And so we all know when you try to look at it, and when you looked at this in the past, actually I can show you. So when you look at this one, and maybe David, you can bring this up, this slide up. But when you look, you can see a lot of variations going on there. And as we all know, that happens. You have influxes, so your denominator may change. So that's for a variety of reasons. We said, okay, to start with, we're going to look at a situation that's really difficult, and it may be 40% moving to 60, and then we did the 60 to 80, 80 to 90, and 90 to 95, looking at UNHCR's and other health information system data.
And building on that, what can be done when the baseline coverage is less than 40?
Yes. At this point, you're going to have to choose the limited is 40 to 60%. I think it's going to be that would be assuming there's a serious acute emergency at this stage where you either don't have the data. I think it's going to be when you're in the middle. Let's say you have 100,000 people crossing the border immediately. You may be able to run this, and you can run it at different scenarios to actually see what may be appropriate for your area. But there are also, in an acute situation, some things that we know. You have the minimum initial service package for maternal child health. There are some things that you just need to do in these settings. I think this may be able to help you in terms of nuanced, but likely it's going to be, so it can be used there, and you can be able to see. I mean, for example, without even using the tool, we know that prevention activities will ultimately save more lives and are more cost effective than more expensive. We know that neonatal, at least in maybe more stable situations, neonatals or deaths are not sufficiently examined. So it should be able to help you to prioritize, but likely if you're below 40%, you're really in this massive acute emergency, and you should follow the existing guidance, and then you can look at this to maybe validate and use the 40 to 60. Kelsey, anything to add on that?
Yeah, maybe just to add on the question about the data sources and linking to existing data sources. So the coverage data you provide yourself. So if you want to use Squeak, or you want to use, in Uganda they have something called the FSNA, which is a nutrition assessment. If you have HIS data or other program data, you can use whatever data you want to use and that you have available. And as Paul said, if you don't have data, you might either, kind of feel it out and think, well, I'm not doing that great, I'm not doing that poorly, let me choose the 60 to 80% scale up scenario. So please bring in whatever data you have, and that is one of the reasons we went with this approach where you don't actually enter the exact coverage and we don't provide you with any defaults, but you can use all the data that you have. I saw, related to the coverage question, there was a question about how do you choose that coverage level. So as I said, it's based on your own setting. So pick the one that you feel best represents your setting. And, if you're really not sure, another thing you could do would be to run the tool with the different coverage scale up scenarios and see if the results change significantly for your setting. Some people said, but I'm at 55%. Do I choose 40 to 60 or 60 to 80? It's really up to you. And in that case, I personally would choose 60 to 80 because you're at 55%, you're nearly at 60%. But you could run the model both ways and see what the differences are.
Thank you, Kelsey. A related question is about to what extent is it possible to take into account the context of the implementation of the interventions within HLIST? So to what extent are the results context specific?
If I understand correctly, the results are, Kelsey kind of hit on this a little bit, is that the results that we're using are from, and as you can look at this in the ListSave tool, so their evidence and the effectiveness is in non-humanitarian settings. And what where we're not at this point, because frankly the data does not exist, it would be looking more at implementation science and say, okay, realistically, if you're going to be doing measles vaccination and you're going to be saving, it showed the current data in a low income country shows you this is how many lives will be saved. But when we do further studies, eventually we, meaning the broader humanitarian community, and we have better data to show, well, in fact, the effectiveness may be less or maybe more, then we will eventually be able to change this. But what we did is we piggybacked on an existing system list, because as we know, there are limitations in the effectiveness data and implementation science currently in humanitarian settings. I'd also add something else, is that Kelsey and I spent a lot of time going back and forth and looking at many of the indicators themselves for coverage in humanitarian settings, and they don't always match exactly the 60 plus indicators in the list. So we had to make decisions, do we include it, do we not? And in particularly in the WASH setting, for example, a lot of the WASH folks say, well, we use 15 liters per person per day as a minimum in emergency standards, for example. How does that relate to list? And the problem is, or the issue is, that there really is insufficient data, particularly on effectiveness, to look at how many lives saved by using 15 liters per person per day. It's a faiblesse, it's a weakness currently in the humanitarian system. So some of the indicators that we do use in the humanitarian system are not in list currently, and there is not sufficient evidence behind them for us to move and include them at present. But we've talked to the list team, and in the future, if there are stronger studies that allow us to do this, we would do it.
Okay.
Kelsey, anything to add? Or?
Yeah, maybe just to add, the list results are only one step of the 7-step process. And even in that one step, you have the option to customize the results to your setting. So we're currently offering customization of your demographic profile, your nutrition indicators. Of course, you choose the coverage levels. And in the future, we hope to be able to offer additional modifications that users will be able to make to further customize the list results to their setting. That said, the other steps of the process are all extremely context specific. So, Paul, I don't know if you want to pull up quickly, I think it's slide 4, just to reiterate, the majority of the process, the brainstorming activities to increase intervention coverage, estimating the incremental costs, and then doing your feasibility assessment, making your final decision, and then implementing, all of that is user generated. We did some testing in Uganda last year. Someone said, it would be so great if you provided a list of common activities that have been proven to increase coverage of treatment for MAM, for example. And we thought about that, and actually we don't want to do that specifically, because what works in one setting might not work in another setting. You know your context the best. So instead of having us tell you what might work or might not, you need to take into consideration what you've already tried, all of the context-specific characteristics of your setting, the capabilities of your partners, your resource availability, all of these context-specific things, and figure out what might work for me in my setting. And then try it. And if it doesn't work, then you can try something else. But, I would say the majority of the process is very customized to your setting, because you're driving the process. We're just providing a framework and a methodology to allow you to do that.
Maybe linking on or building on that, do you have any recommendation on how to choose a point prevalence when it comes from previous surveys? So all the surveys, would you, for example, recommend to use the upper confidence limit if in presence of aggravating factors? Or do you have any broader, maybe this is very specific, but do you have any broader recommendations on how to choose the prevalence to input if you don't have recent data?
That's not an easy question. Good question, and not an easy answer. And we ran into that in Uganda with a survey that was supposed to be for this past year, 2019, but it didn't work out, and so we didn't have those results. And all we had was the previous year before, and things change. And this is again where I would emphasize what Kelsey was saying in terms of context. So we want to give you the framework and the tool, but it's up to you then to decide and think about what has happened. So if you have a data, let's say your GAM and your SAM, or your data for looking at hygiene or other areas, and it's a year and a half old, you need to think about your context and say, well, in fact, since then we've had a lot of money and we've improved, so I may have to choose this, or we've had a huge influx, or we've had a huge stock out of various things, and therefore it's likely our prevalence is less. You can certainly think about your lower and upper confidence intervals, but I think it's rather more you thinking about it and choosing according to your context, and use as we talked about, use this tool to put in different scenarios and just see what comes up, because in some situations, they can be quite different and they can be quite similar depending on overall context. So you may try two different scenarios, and actually you see, well, the prioritization is not very different, or if it really is different, then you need to think through. And this is where I think we recommend this process of working with others and amongst the various sectors. Kelsey?
Otherwise, we have one last question.
Go ahead.
Yeah. Let's talk maybe a bit more about who are the users of HList. So who is designed this for, and to what extent it could be used by donors for reporting results?
Maybe Kelsey, over to you for that, if you'd like.
Yeah, great question. So our original intention when we came up with this tool, I say we, and it was really Paul, was so the idea was, when you're in the planning phase and you're basically, your head's going in a million directions and you need just a bit of guidance, where do I start and what should I focus on? We think that's maybe the best or most straightforward use of the tool. I think it can also be used quite powerfully for advocacy purposes. So, you can advocate to your donors, your funders, we would like to increase coverage of X intervention from 60% to 80%. But if you can translate that argument into lives saved, and say, if we focus on these 10 interventions this year and really try to increase coverage, then we can save, of all the potential lives that we could save if we did a little bit of everything, we can save 90% of those lives by focusing really hard on these, top 10 interventions. That's a really powerful argument. So I think those are the primary purposes. It's not really designed for, let's say, on the reporting phase, because we're not giving you the exact number of lives saved. So I think normally donors would include that type of information if they were going to include something like that in a report. So we saved this year 1,200 lives or 1,500 lives. We do not give you that number. We just give you the prioritized ranking of the interventions in terms of the ones that save the most lives. So just to reiterate, I think for planning and advocacy would be the best uses.
Great, thank you. We're coming close to the end now, so a couple quick thank yous and then also a request to all of you. So thank yous to the list team at Hopkins, who put in an inordinate amount of time helping us and dealing with, and we kept on coming to them and saying, we've got this issue here, and it was complicated in a humanitarian setting, and thank you very much for that. Thanks to the Gates Foundation, who is both funded LIST itself and humanitarian LIST. A particular thank you to UNHCR, the High Commissioner for Refugees, who we've worked with consistently throughout this, and we've tested in many of their settlements. And then finally, what next? And what we're hoping that this is the beginning. And recently, Kelsey and I presented this to various UN agencies, UNICEF, WHO, UNFPA, and of course UNHCR in Geneva, and to various NGOs. What we would love is for you to trial this and then give us feedback, because what we want to do is to see how this can be used in various scenarios, to see how we can improve it. We'll also be working to improve and make it even more context specific over time. And then hopefully together this can be one tool that should be able to help you in your planning and also potentially for advocacy. So with that, I think we end. Thank you, Chiara. Thank you so much, Kelsey. And thank you for all of you that were on this webinar. This will be recorded, and it'll be on the Hopkins Center for Humanitarian Health's website as well for future listening and learning. Thank you very much, everyone.